Good morning, ladies and gentlemen. I would like to thank the organizing committee for asking me to present the Nori flow phenomenon. Nori flow phenomena, defined as a TIMI-3 during PCI procedure despite opening of the occluded vessel. The incidence varies from 5 to 30, and some literature reports up to 60%. As you know, it is a serious prognostic sign that lead to a poor healing of infarcted area in the setup of acute myocardial infarction. This results in adverse left ventricular remodeling and adverse cardiac event of arrhythmia, heart failure, and death. Animal studies have shown that occlusion of vessel of coronary artery more than 90 minutes will lead to the ischemia that lead to endothelial membrane swelling, which compromise the lumen of a small vessel of coronary artery. In addition, endothelial cell swelling lead to dysfunction and the release of endotoxin. Another theory is the microemboli that is attributed to the small capillary vessel. Furthermore, microvascular arterial spasm was postulated to be a cause of Nori flow phenomenon. As a result of Nori flow, there will be a reduction or deprivation of blood to the myocardium that reduces the macrophage, which act to remove the debris and a humoral factor which needed for healing. This leads to adverse remodeling and arrhythmia, left ventricular function, and even death. What is the situation that Nori flow phenomena happen? PCI to degenerative vein graft, acute myocardial infarction using rotablation in calcified vessel, and a stable angina and lesion containing significant thrombus. What are the risk factors? Diabetes being postulated, hypertension, hyperlipidemia, smoking, and high incidence in patients with renal impairment. Sorry. The most important in this problem is to prevent it before it happens. So controlled hyperglycemia is important, as has been demonstrated by Dr. Mollasberg, being published in Interventional Cardiology Journal. Statin therapy prior to the procedure, 2 hours to 48 hours, has demonstrated reduction of Nori flow by 5%, demonstrated by Lyon. Shortening of door ballooning time in acute myocardial infarction will reduce the ischemia that subsequently reduce the Nori flow phenomenon. How to prevent this phenomenon during PCI if it's happened, before it happens, is if there is a thrombus, aspiration of large thrombus has demonstrated that the Nori flow phenomenon will be reduced by Massini, published in JACC, or using distal protective device, filter wire or angiojet, although there is no long-term reduction of mortality in this study. Primary stenting is advisable if there is a thrombus-containing lesion, and when we deploy the stent, it is better to avoid high pressure when we deploy the stent and avoid long stent. Now, if Nori flow happens, there are 2 scenarios that we have to consider. The first scenario, when you have Nori flow with extremely low blood pressure below 50, and we publish data on that. What we should do, we should avoid in this situation vasodilator. When the blood pressure below 50, we should improve the blood pressure by pulling the guiding catheter, keeping the guide wire, and giving norepinephrine around 60 to 100. This will improve the pressure, and then we can use after that the vasodilator. The second scenario, when you have normal blood pressure, then in these cases, we can use the capridine, adenosine, NG10, and other, whether through the guiding or distal microcatheter. Zavala have shown in studying 1,600 patients, he demonstrated 10 patients of no reflow. In all these cases, he used vasodilator, even with a low blood pressure. The consequence of that, he has 60% of those patients went into bradycardia, VF that need cardiopulmonary station and ventilation. So my advice in this scenario is to improve the blood pressure before giving vasodilator. But what happens if no reflow has established? There is a study by Yetkin, published in JACC, that he gave an infusion of adenosine 70 mic per kilogram per hour with or without a GP inhibitor. I will show you a case which we have done. This is a 67-year-old lady. She had 2 PCI in the Gulf area. She had triple vessel disease with borderline left main, but they prefer to do PCI. I thought it is a surgical case, but it seemed to be they prefer to do the PCI. So they did right coronary and LID for that lady, and she came 3 months later with another chest pain. And they found that there is some dissection and restenosis proximal to the LID. And they stented, but they left the borderline left main, the diagonal, and the circ. She came to us with angina, and this is her coronary angiogram. As you see, she has a left main. I think it's significant. It's not 60, it's more than that. The LID looked good, patent. The circ has significant lesion. And as you see, the diagonal has ostial and proximal lesion. And the right coronary has been stented at the mid-distal segment with good flow and no restenosis. So what we decided, we brought her to our cath lab to dilate the circ, the diagonal, and possibly IVAS the left main, although it looked angiographically significant lesion. So we put 2 wires. Once we put the 2 wires in, what happened? There was no flow in the LID yet. As you have seen, the LID was patent, and the circ. The blood pressure dropped from 50 to nearly 40. At this stage, what we were thinking, is it a spasm, dissection, or embolization? Is it a combination of the two? It was difficult, but we could not see any dissection in the left main, neither air or clot embolization. What we have to do? What we did, I pulled the guiding catheter into the arch of the aorta. I give norepinephrine 6 mic, and then the blood pressure improved. Meanwhile, I asked the nurse to prepare a stent to stent the left main. We stent the left main, and before we stented the flow to the LID was improved, and we stent the left main, the flow get better. Then we gave intracoronary nitroglycerin, and this is the blood pressure, and the heart rate was better. Second, then we went into the circ, we fixed it, and then we did POTS for the left main with 4.5. And then we went to the LID diagonal. The LID was patent, so we put a stent, put in 2 wire LID, and put a balloon in the LID and a stent in the diagonal. And this is the final result of the patient. What are the lessons to learn from this patient that, as you know, the blood pressure is the cardiac output and peripheral resistance. When we lost the cardiac output as a consequence of no reflow, we have to improve the peripheral resistance, so we give norepinephrine. And then we improve the blood pressure. Then we went to give a vasodilator through the coronary guiding catheter. Thank you.